Alright, so here we're talking about the difference between posterior pelvic tilt, drawing in, and ab brace. Okay? Posterior pelvic tilt comes from the pelvis. It's going to involve your glutes and your core, a combination of the two. Slight motion here in hook line. You want to see more exaggerated on the patient, you can have them legs extended and have them try to tuck their pelvis in. Different from a drawing in maneuver, which is basically you're just going to cue the patient, suck their belly button down into their spine, into the table. See, you don't get the tilt in the pelvis with that one. And the ab brace is just contracting your abs. Relatively no motion. Alright, so we're going to talk about lateral shift. Okay, a lateral shift in the spine is different than a side bend. A side bend, spine is curving. Lateral shift is it just shears laterally. So you get a patient with a disc injury, could be just a bony joint problem, alright, but most likely it's coming from a disc impingement where they're going to get shifted out of place and their pelvis is going to shift away from the side of radicular symptoms or the side of dysfunction. So if my right side, if I have the herniation on the right side, I'm going to shift out of there, and when they try to like stand up straight, they're going to get the pain shooting down their back. So the way we correct that is by putting there's different manual techniques, but the way we correct it with exercise is we put that side, that pelvis against the wall. We put that shoulder against the wall opposite way. So if my hip is pushed to the left, put the right shoulder on the wall, have them take their hand and just push straight in. What you got to be careful for is that they don't flex when they do it. Alright, because a lot of times these patients with the disc herniation are going to be flexed and deviated away. When they go to a forward bend, it'll look like that. Okay, so when they have this shift, right, and they come in, they walk into the clinic like this. Okay, you're gonna put them as straight as they can and as much extension as they can. All right, and you're gonna gradually progress. Maybe they start here, and you gradually progress them to straight. You want to get them in as much extension as possible. Put that shoulder against the wall, and have them push into the wall. Patient-wise, I do both sides. Just do the one side that's kinked out. The movement pattern these patients will have with disc herniation is on sit to stand. Okay, because flexion is going to increase their symptoms. Now, actually, when you sit, you have a little bit of a flexed posture, and then when you stand, you kind of come forward into a further flexed posture and stand. However, these patients want to avoid that flexion posture, so when they sit, they'll scoot their butt forward and lean back to keep their back neutral / extended. And then when they stand, they'll keep scooting even more, and they'll keep their back flat and come up like so. Okay, the only problem is, in this position, they never get to use their glutes. So you want to train them, instead of coming up here and pushing their pelvis forward that way, to push their butt straight up. Okay, so they're gonna scoot themselves to the edge of the chair like normal. Okay, and instead of flexing forward, you're just gonna teach them to push from here and come up, so they keep their spine extended. All right, but they don't get this dysfunctional pattern of like leaning back as they come up. This video, we're gonna talk about passive positioning of the spine. All right, so these positions are gonna allow you to have your patient rest in the position that we're trying to treat. Extension bias, flexion bias, or neutral spine. And this will help you with starting points for your exercises. So when you're starting with your isometric exercises in the acute phase, you're going to position them into the position that we're looking to treat them in. Alright, so I'm going to start in supine. And if you have supine, no pillow, legs extended, you'll be in a relative lumbar extension, as you'll be able to feel there's a little bit of space between your low back and the floor. To get rid of that extension, put them at neutral spine. You're just going to go to hook line, all right, and you should feel that space go away. All right, in the cervical spine, if you want cervical flexion, you're gonna put a pillow. Obviously, higher pillows gonna further flex the neck. If you want cervical extension in supine, you're gonna put a towel roll right where my arm is here, and that's gonna prop the neck up, put them into cervical extension. All right, next position is gonna be prone. So prone is a naturally lumbar extended position. If you want to get rid of that extension but keep them in prone, such as if you're doing manual therapy or something like that, you're going to put a pillow underneath their abdomen. Okay, don't go too low. Sometimes therapists will do this, and then you still have the extended position. Or if they put it too high, again, same thing, even more extended position. So based on the amount of lordosis they have, so even for me, I should probably have another pillow to kind of get my body propped up to about there. Okay, to get out of that extended position. All right. Sometimes the tables will have a face cut out so they can keep their head straight down, cervical spine straight down, instead of leaning to the side. It's a lot of rotation for a patient with cervical pain. Sitting is going to promote a relative lumbar flexion. All right, as gravity pulls you down, it's going to be a flexion. If you want to further increase that flexion, you just put their feet up onto a stool. Okay, or you can put one foot if it's unilateral symptomatic side. All right, to promote extension, you're going to put a little towel. I'm going to use a pillow. It's a little bit big, but you get the idea. You're going to put the pillow right in their back so that when they lean, you get this lumbar extension. All right, that's to promote extension in a seated position. Standing is extension, right? And then the for a patient who needs to stand all the time, but extension is going to be bad for them, I'll cue them if they have an opportunity, just put their foot up on something to take the extension out, get a little flexion, all right, to give their body a break from the extended position.